Hello again, everyone, and welcome to another edition of Health Center Dialogues. I'm Lorraine Brooks, and I'm here with my excellent co-host, Julie Black-Peart, from our Physician Assistance Program here at Downstate Medical Center. And we're here for another edition of Health Center Dialogues, where we're going to be talking again to one of our illustrious professors in the School of Public Health, Dr. Daniel Elke. Some of you might remember that Dr. Elke has been on our show before to talk about the provisions of what we're calling Obamacare, but the official name is something which he'll tell us because I can never remember the whole thing. But we're going to be talking today about some further provisions of the Affordable Care Act. I know it can be very confusing. There's a lot of information, there's a lot of misinformation, there's a lot of myths, there's just a lot of confusion about it. I myself am in the middle of learning about some of the provisions, and I'm sure that Dr. Elke can elucidate some of the things that many people might be confused about. So Dr. Elke, thank you for coming on the show again, and it's a pleasure to have you again.
Thank you. Welcome again.
And Julie, it's always a pleasure to work with you as well.
As always.
So Dr. Elke, what is it? What is this thing that we're calling the Affordable Care Act? It's so confusing on so many levels, and I know that as a political exercise, and I'm not the most politically astute person in the world, but just as a political exercise, it's just seemed to me, and you'll tell me if I'm wrong, that it got so compromised, so
absolutely.
watered down, so, I mean, it's good to have consensus, of course we have to do that, but it just seemed to me that it got, there was so much compromise that it kind of took some of the teeth out of it. But I wonder if you could, just kind of.
Absolutely.
I don't even know what I'm asking.
I'm glad you brought that up.
Go for it.
Absolutely. Well, partly the Patient Protection and Affordable Care Act, to give it its full name,
Patient Protection and Affordable Care Act.
Is a reaction to the failed attempt at health reform back in the 1990s. Many of you may remember President Clinton and Hillary Clinton actually attempted to wholesale reform our healthcare system back in the 1990s. That failed not so much because of the merits of the plan or lack thereof, but actually because of the way the politics of it were managed. Many now believe that what went wrong effectively was you had a group of experts working under the administration led by Hillary Clinton and several others who themselves, with the assistance of an expert here, an expert there, individually came up with a huge reform plan. After many, many months of mystery, by the way, in which very little was leaked out of this process, it was then delivered to Congress. And I've heard it claimed that at that point, many Congress people simply viewed it with disdain. It's said that Senator Daniel Patrick Moynihan, the late Daniel Patrick Moynihan from our own state of New York, absolutely gave it one look and said, I'm not even going to read it. Because Congress was not involved from day one at all. So fast forward a bit, and you have some of the Clinton veterans in the White House, including most notably Rahm Emanuel, who was there. He witnessed this. And he wanted to make sure the same thing didn't happen again. And as a result, he decided the way we do this is get immediate congressional buy-in at the very top. In fact, we won't even write the plan ourselves. We'll have Congress write it. Well, the problem is Congress is so decentralized. There are all these different Congress people, different committees and everything else. It takes a long time for Congress to agree on anything.
Are you saying that there's a problem with Congress? Is that what you're saying?
Just a little bit. Absolutely. It's a little wee bit. And so it took months and months for a plan to unfold. The administration gave some priorities that it wanted to see, but beyond that, largely left it to Congress. So after a certain point, the administration had to step in and say, look, it's been months. Let's get this show on the road. And by then, so many people had been involved. There had been so much back and forth, quite a bit of hostility between members of the two parties, that it really created, I think, a toxic environment.
Can I interrupt you just for 1 second?
Absolutely.
Why? I mean, if we're professing, or I mean, maybe we're not, professing that we want to provide affordable health care and patient access and all the things that we claim, what's up with all the animosity?
I think, yeah.
No, please go
Thank
ahead.
you. Absolutely. I think the toxicity partly is about more than healthcare. I think a lot of it has to do with the fact that very early on, the president said, look, this is my pet project. This is what I want to focus on in the early part of my presidency. Any president who defines a project in that way is going to attract immediate opposition from the other party. The other party, after all, it's the other party's job to effectively foil any president who's in office. That's what the opposition does.
Right, exactly.
So because it was so closely associated with the president, I think the stakes were raised when it came to opposition to the legislation as well.
That's so sad, though. I mean, you would think, Congress, we're supposed to be trying to help our people, right? Not pull them down, bring them down, make things more difficult.
And again,
now that the Republicans are controlling both sides, what does that mean for us now? What does that mean for this whole Affordable Care Act?
And now that Obama is in his last,
he's on his way out. What did they do? We don't care anymore now. It's okay now.
Well,
will the law be overturned? Do you think maybe?
I think it could be overturned, but it may not necessarily be overturned because of the Republican will for that to occur. It should be noted that just recently we had, depending on how you count it, about the 50th, possibly the 57th repeal vote. The legislation has been repealed 50 plus times in the House of Representatives. However, because
what do
there
you
was
mean by repealed?
Canceled, struck out. By the House of Representatives. We have two houses of Congress, obviously. The Senate wouldn't go along with it, and obviously the President wouldn't go along with it. So this was a symbolic exercise. So we've now seen at least 50 attempts at that, and there will likely be a few more. However, I think more and more we're seeing Republicans, including quite a few Republican governors, feel that, well, this is actually a good deal for my state, particularly in those states that are getting more money for expanding Medicaid, and not just in the way that they would that the administration would desire to do so, but often through managed care, through private intermediaries. That makes it easier for Republican governors to say, okay, this is something that I can get on board with.
Benefit.
And so really, I think the Republican threat in Congress is fairly low. At this point. That's not to say it's non-existent, but it's fairly low. The real threat comes from the Supreme Court, I think. There's currently a case before the Supreme Court called the King case, which will be argued in March, and then the decision will likely come down in July. It'll be one of the last decisions they come out with. Like students, they wait until the last minute to get their big projects finished and then turn it right in, and then they're off on vacation. So by July, we should see a ruling in that case. And what that case involves is the literal language of the legislation. The legislation was written in such a way that the subsidies I mentioned go toward helping people buy health insurance on the exchanges would only be available to exchanges run by the states. The problem with that is at that time only be available to those within those states that had exchanges run by the states, effectively. That's what the plaintiffs in the King case are arguing, all right? And that's what the language seems to say, because I believe at the time the administration believed that, well, it was such a good deal that every state would go along with it, would create their own exchange.
And that's not what happened.
Because of politics, they didn't create their own exchanges. So now we have about half and half of states that have a state-based exchange and those that have their exchange run by the federal government.
And that's perfectly okay.
Absolutely, under the law.
They don't have to.
They do not have to do so. However, if you interpret the law as written, that then means that those states that have federal-run exchanges would not be eligible to get subsidies delivered to those who buy insurance on those exchanges. And so that could mean that immediately or soon after the ruling, many people who bought health insurance or will be buying health insurance the next year wouldn't be getting those subsidies at all, and a lot of coverage would then become unaffordable. And many people are worried that
only in those states.
Only in those states. However, again, that's about half the country, and it's a huge amount of people, and many wonder if then that would be the first domino that brings the whole edifice down.
Okay, does this also bring into play what people are concerned about? Oh, well, I used to have insurance, and then the price is going to go up, I won't be able to afford it anymore, right? Okay, so.
Well, this it's partly because the Affordable Care Act has a list of benefits that must be covered by insurance companies. In some cases, more generous than plans previously. And as a result, some plans that don't quite meet that definition, that don't have some of those required benefits, are being canceled by the insurance companies. So people in some cases are finding the plan they had is no longer available in its exact form, and the insurance company wants to charge a little more for these extra benefits. So you're getting a better product in the end, but you're also paying a little bit more in some cases.
That's hard. That's a hard case to make.
It
for
is.
somebody
It
who's
is.
struggling
Absolutely.
to pay.
Yeah, or
Absolutely.
people who are, you know, they have illness already, and the plan that they had was covering all of their needs, and maybe the new plan is not covering all their needs. So what do people do in that regard?
I think many people who will really be struggling will be receiving those subsidies. That's why these subsidies are so vitally important, I think. And some people who have lost coverage have actually not been aware that they are actually subject to these subsidies, that they get assistance in buying new coverage, and that the coverage they get could in fact be better
Is
than
there
that.
eligibility criteria for
It's
the
between
subsidy?
about 133% of the federal poverty line and 400% of the federal poverty line.
What's the
Now,
federal poverty line?
The federal poverty line is it's very, very low. I believe at last for an individual, it might be not much more than $10,000 for an individual.
So 138% of $10,000 is $13,000.
Up to 400%. So 400% actually covers quite a few individuals
So that would
at
be
the end of the day.
$14,000.
40,000 for an individual. For a
$40,000.
family, you know, it could go up obviously.
So
yeah.
fortunately for our viewing audience, we're in a state that has its own. So
Yes.
we don't have to worry about that. But just for people's general
Well, but
knowledge, they can
people have
understand
Absolutely. And
other
exactly
states,
what the
yeah.
whole system is about.
And another key plank, really, of the plan, by the way, that we haven't mentioned yet, is the Medicaid expansion.
Please talk about that. Yeah.
Originally, the legislation, and here the Supreme Court comes back into our story, originally the legislation called for every state to raise their Medicaid income eligibility level up to about 133% of the federal poverty line, again, that magic number.
Okay.
That's significant because in some states, particularly in the South, like Alabama, the rates are close, eligibility rate is closer to about 50 or 60%. Very, very low. So imagine bringing that up to 133%. That brings a lot of new people in who will now be eligible for Medicaid.
Okay.
The Supreme Court, however, decided that this in effect represented coercion, because what the administration originally said was if states chose not to expand their Medicaid program, they would have all of the federal share of their Medicaid money taken away. And the Supreme Court decided that this is tantamount to coercion. It's not exactly forcing
Coercion
them,
means-
but
right, we're not exactly.
Yeah, it's
trying
hard
but
to
it's
say no.
We're
pretty
gonna take
close.
away your money.
Exactly.
Pretty
They're
hard to
basically
say
a deal
no.
you can't refuse.
Yeah.
So the Supreme Court ruled that it had to be voluntary, that states would still receive their Medicaid money if they chose
Even
not
if
to
they
expand.
didn't. Okay.
So as a result, again, you get a similar breakdown. About half the states decided to go along and expand their Medicaid programs. About half decided to keep their Medicaid programs largely as is. New York was one of the states that expanded, although we were almost up to that rate anyway, so it really didn't require much in the way of additional investment. But for some states, it would have made a huge difference. When you're talking about a state like Texas, for instance, which is approaching about a third of the populace uninsured, an expansion of Medicaid could have made a huge difference.
So I mean, say you retire, say you're living in New York and you retire and you want to move to Texas, or you want to move to North Carolina, or you want to move to...
Depending on your age, hopefully you would become eligible for Medicare at that point, and that would largely cover your Medicare. That's
so Medicare is the
Medicare
over 65
exactly,
that everybody's
exactly.
eligible for.
Right.
Medicaid is you have to have a certain
It's an
certain
income eligibility limit,
requirements.
and
Right.
it should be noted too that up to this point there was also a categorical standard. That is, in addition to that income eligibility limit, in many cases those who were childless, for instance, were not eligible for Medicaid. And now under the expansion, all groups under that 133% are eligible, again excluding undocumented immigrants.
What you don't know, I'm telling you, this document you said is like 1,000 pages.
It is, yes.
Oh my goodness, and you're so knowledgeable about the whole
Thank
thing.
you, thank you.
It's
I appreciate
amazing.
it.
It's amazing. I had a question. You know, sometimes I'm getting so intrigued by everything you're saying. I had a question right on the tip of my tongue, and now it just seems to have eluded
Well,
me.
you know, I
Go right ahead.
is it still eluding you? Or
No, that's a little frog in the
Oh,
throat.
okay. Is it still eluding you? I mean, I don't want to interrupt.
Yes, it
you.
is eluding.
Oh, okay. I just wanted to talk a second again about the Medicaid and
Yes.
Medicare thing. I think that a lot of people, and you know, myself possibly included, I mean, I'm at that age where, you know, maybe I can retire, maybe I can't retire, maybe I will retire, maybe I won't retire, maybe I'll stay in New York, maybe I won't stay in New York. And these are some of the things that you have to start weighing now. If I leave New York, you know, how is that going to impact
particularly for those who are, sorry to interrupt, particularly for those who are thinking of retiring before the age of 65.
Before the age of 65.
At 65,
because, you know, I'm only 40, and that's really early to retire, you know what I'm saying?
So, you know, that would be a consideration.
That's a consideration.
Absolutely. It depends on, you know, if you want to move to, say, a warmer, sunnier place, you have to check to see if that warmer, sunnier place, for instance, has Medicaid at a certain level, and what the healthcare situation is in those states. Many times I like to say that we don't have a single healthcare system in the United States. We have 50 different healthcare systems, really.
See, nobody used to ever really think about this stuff before because it was just kind of a given. So all the other elements that we know about Medicaid Part A and Part B and D and all of those things, are there changes in there or not really?
Actually, Medicare is left largely untouched when it comes to its essentials. So Part A, B, C, D, etc. are largely left untouched. There was an effort originally underway under the Affordable Care Act to actually try to cut some of the reimbursements that were going to the private Part C Medicare Advantage plans, the private managed care organizations, because it was thought that the federal government was effectively giving them too sweet a deal. However, after lobbying by the insurance companies, now Democrats and Republicans are united in keeping that reimbursement about where it was. So yes, absolutely. It should be noted, though, that there are some experiments going on within Medicare. For instance, when it comes to trying mechanisms like bundled payments, paying physicians differently, paying based on evidence, based on outcomes, that is being attempted under pilot projects within Medicare. So while the essentials of Medicare are not changing, small parts of it are being perhaps rejiggered a bit.
Right. So if you have Medicare, you'll have your basic Medicare plan, and then you'll have to pick during this open enrollment period now the secondary plan that you're going to be using, whichever one it might happen to be, and you go to the same website. And you
if you are thinking of getting Medigap coverage, in many cases, you know, Medicare will cover most of the expenses.
Back up for one second. Explain Medigap. What does that mean?
Medigap is basically coverage, private coverage that people have traditionally purchased to cover some of the extras that Medicare doesn't always cover. But particularly under the Part C, the Advantage plans, one of the chief draws of Medicare Advantage is that it now covers a lot of those extras. And that's why I believe just over a third of Medicare beneficiaries now get their plans through managed care under Part C, under Medicare Advantage, because it covers those extras and it obviates the need for Medigap coverage altogether. So it's hoped, you know, probably in the future that, again, Medigap coverage wouldn't really be necessary, and that, you know, it'd be a straightforward process at the age of 65. You got your Medicare, you're ready to go.
So here's a question. I'm 60, I'm uninsured, I turn 65. Do I automatically get Medicare?
Yes, absolutely, absolutely. So you do have, up to this point, you have had many people who are in the unfortunate spot where they're basically waiting until they're eligible for Medicare, putting off doctor's appointments, putting off prescriptions. Absolutely, absolutely. And unfortunately, on some level, that will probably continue because of the holes in coverage that we talked about.
Right. And what about employment? And, you know, because most of our health care traditionally has been covered through employment.
Absolutely.
And you know, the better your job, or the bigger your company, or the more, you know, generous your company, the better your plan. Is that going to be affected in any way under the Affordable Care Act?
It could be. It would be affected indirectly in some ways. There are some employers, it is believed, who will decide, well, you know, maybe it's not such a good deal anymore for me to provide health benefits to my employees. There are now marketplaces available. People are now able to purchase insurance on those marketplaces. Why not offload individuals onto the exchanges? Now, those employers that take that tack have to pay a penalty. So they have to decide, is that penalty going to be about or greater than the cost of covering employees? But it is thought that some employers could simply,
from having to,
absolutely.
And with that, there goes some jobs.
Yes.
Of course, absolutely.
So, I mean, there's so many pros and cons to this thing. I mean, you have your big conglomerate, you pay, and then you've got your employees, and they're paying into it any doggone way, the insurance, health insurance, 9 times out of 10, right? So it's darned if you do and darned darned if you don't.
Is it going to affect the premiums for people who are currently insured under their employ? Because we're currently insured under S.U.N.Y, right?
Absolutely.
How does that plan change?
Absolutely. In some,
I'm just saying.
in some cases, because insurers must now cover a larger population, in some ways a sicker population, there will be, I think, a desire to try to shift costs in such a way that many plans do see some increase in premiums. I think to say otherwise would be blurring the picture a bit. So
and if we're covering people who were previously not covered, or conditions or situations or groups of people who were previously not covered, somebody has to absorb
someone
that
has
cost,
to pay that cost, absolutely. So where there are extra benefits, there are going to be extra costs. It depends how we pay for it. In this country, if you call something a tax, we're allergic to it, we don't want to pay for it. If you disguise it in some way, if you say it's a licensing fee, if you say it's something else, or if it's fairly invisible, tucked within a larger insurance bill, people don't complain nearly as much, but you're still paying that cost. And for some people, it could be fairly significant.
Wow. Is there any difference for people who have pre-existing conditions now as opposed to those who don't when you go to
Absolutely. Well, that's one of the chief drawing points, really, of the Affordable Care Act, and one of the ways in which it really does expand coverage in a very meaningful way. That is, insurers are no longer allowed to discriminate on the basis of pre-existing condition. Not only can they no longer refuse coverage, they can't charge significantly more for those who suffer from pre-existing conditions. So that's going to bring in a larger population, but it also brings in potentially a sicker population that could raise premiums for everyone else. So that's the downside, if you will.
But now, just if I could just throw this in, if you have been uninsured and you therefore have not been accessing health care, you are going to be sicker.
Absolutely.
Theoretically, at least.
Yes.
Though if you had been
absolutely
cared for all along.
Yes.
So that's kind of the other side of the same triple edge.
Absolutely. And again, that's an upward pressure on costs. You do see many people who are, again, waiting until they receive coverage to get care that they've long needed.
They're really burning the candle at both ends here, you know, and what they're doing then, which is also increasing cost, is that they're going to the emergency room for basic needs and all kind of things, non-emergent things like that, and that's not the intention of an emergency room. So this gives them an opportunity. If you're a family and you've got kids, they need to be able to get their vaccinations and their preventative care and just whatever it is, and now these things are available to those folks.
And that's one of the way in which indirectly, at least, this legislation does try to reshape really the way healthcare is delivered in this country, because there's an attempt being made to make sure that people don't go to the emergency room as their first point of contact with the healthcare system for non-emergency needs. For those who were uninsured in the past, of course, that was really the only alternative in many cases, or perhaps a community health clinic. But outside of that, there really weren't many options. It's thought that for the newly insured, they will now be able to go to a primary care physician, hopefully develop a relationship there, no longer rely on the emergency room for all of their care. And this is one of the reasons, by the way, that some federal payments to hospitals are actually decreasing under the Affordable Care Act. Again, another way we're trying to pay for this legislation. They're cutting some of the payments to those who serve a disproportionate share population. For instance, they get extra payments from the federal government to cover those who are uninsured. And
we're seeing a surge in these community clinics growing now, too, that are staffed in large part a lot by nurse practitioners and physician assistants, because people have a need to be able to go, because you can't always you call your primary care for an appointment, and the next slot you can get is like in 2 weeks, and you've got a fever now, you know? So you know, what are you going to do? What are they doing to try to encourage more primary care doctors to join in?
Well, they are developing programs of loan forgiveness, in some cases cutting loan repayment, putting limits on the amount of time a loan has to be paid, particularly for those individuals going into primary care and those going into underserved areas.
Okay, now I'm going to stop you because you did mention that before. Now, those are our new physicians.
Yes.
What about folks have been like, you know, you've been in practice for years now, and you're like, oh, poo-poo, I don't want to do it, or, you know, what reason would they have to get it? How are they getting these?
Well, you know, I think they may be less successful at doing that, actually. They're really hoping, I think, that the new generation of physicians are going to move. And while I think it's hoped that there will be some mid-career changes made, you know, I think that the efforts there don't quite stack up. And that's going to be a real problem when it comes to physician supply in the years to come.
I'm going to have to stop this wonderful and informative discussion here because we're running out of time. But it's so fascinating. I mean, obviously there's weeks worth of material here, and it's so deep and so confusing and so fraught with politics and everything else that we could really. But thank you so much for helping to decipher some of it, and you've been very helpful to me, and I hope our viewing audience. And Julie, thank you again for being such a wonderful co-host.
My pleasure. Thank you.
And Dr. Elke, please come back to the show anytime.
Thank you.
We'll
do.
About the rest of those 1,000 pages.
Absolutely, absolutely.
In the meantime, thank you so much for watching Health Center Dialogues, and please tune in again next time. I'm your co-host, Lorraine Brooks.